Well, welcome and good afternoon or good evening, depending on your time zone. My name is Dr. Amelie, and it is a treat for me to be back with you today. If you were not here for the 1 o'clock meeting, it's 1 o'clock Central Standard Time. It was about 5 hours ago. We had a really good session, and I'm looking forward to another good session tonight. Joining me this evening is Dr. Mimi Secor. And if you were with us at the earlier session, during the middle of it, she got a knock on the door from the FedEx guy.
Yes.
And it was he had a box with her Patrick Mahomes jersey that she ordered since the Super Bowl. Mimi, stand up and let everybody
I ordered it the night of the Super Bowl.
Yeah,
Woo!
night of the Super Bowl. So there you are. So Mimi is here, and of course she's a nurse practitioner who's been in practice for 43 years. She's a family nurse practitioner who, if she hadn't seen it, you don't need to know about it. And it comes to us from Cape Cod. And then we also have Dr. Kathy Baldridge, who right now is in Central Louisiana. And Kathy is a family nurse practitioner. She also is our Louisiana Association of Nurse Practitioners state president. And she's a terrific clinician, and we are very honored to have her as our moderator for this evening's session. So welcome everybody. And Kathy, if you remember, when we left off this morning, besides the fact that it was fun, we had a lot of participants who were interested in talking about the exam and the predictor exams.
Correct.
And I really wanted you to kind of open us up with what an exam looked like, what the report looked like. And while you get that set up, I'll kind of go ahead and introduce it. At the earlier session, people were interested in finding out about a predictor exam. How would you know that you were ready for the exam? And Kathy and I both suggested taking an APEA predictor exam. And people had lots of questions about what that was and what does it tell you? So we kind of left off by saying that it's something that you probably ought to take 2 or 3 weeks before you take the actual certification exam. And what makes this one unique is that it's statistically predictable. And we know that if your number is 70% or greater on the APEA predictor exam, that it correlates with passing the certification exam. So that's kind of where we were when we left off. And if you're new to this session, I want to make sure that Dr. Kathy kind of gives you our Q&A, I don't want to say rules, but these would help you be an active participant, because we really want to reach out to everybody. We want you to feel like you're part of us. And so Dr. Kathy.
I was trying to figure out, I thought I had that particular person's name blocked, but let me figure out just a second.
So we had a lot of participants who sent in questions. They were all just great questions. They just facilitated a good conversation, and we're looking forward to that again tonight. So right now, I think we're going to talk about the certification exam, but since you left us today, feel free to ask questions about any of the content that you viewed or anything that you think needs clarification, or just something that's just not quite right in your brain about any of the content that you heard on video. So,
right, and give me just a second here. And
yeah, so this morning we had some awesome questions on pulmonary that dealt a lot with antibiotics and acute bronchitis. We had questions from participants on COPD. We talked about pregnancy. What else, Mimi? We had lots of things that came up.
A little bit about pneumonia, a little bit about corona, with or without Lyme.
I'm pretty sure this one is without Lyme. So listen, while you have on the Patrick Mahomes jersey, I'll tell you the latest in the state of Louisiana, which is where I am coming to you from, and which is where Kathy is. Sean Payton, who is our beloved coach of the New Orleans Saints, was diagnosed with COVID-19.
Oh, geez.
Apparently he has a different case. I wouldn't say unusual, but he started feeling really, really tired. and then got tested, and his test is positive. So he said he's not running fever. Concerning.
Yes.
He's got it. He's not running fever, but he just had kind of exhaustion.
So how'd he get the test?
Louisiana has good testing. I really have to say, we have an awesome public health department in Lafayette, where I live. I'm sure Sean Payton is in New Orleans, but in Lafayette, we have drive-through screening and even drive-through testing that started. So
amazing.
Okay, there we go. I think I have it fixed. If you want me to go ahead.
Sure, Kathy, that would be great.
Okay, so this is what the report looks like for a predictor exam. Now, what we encourage people to do is when you take a predictor exam, treat it just like a mock certification exam. Allow yourself 3 hours and tell everybody not to call your house. Take your cell phone out of the room. Don't look up answers to questions, because you really want to get a good report to see exactly where you are. And so at the top here, it shows the overall score. For APEA's predictor exam, 70% or better means that you're highly likely to pass the certification exam on the first attempt. Anything in the middle between 65 and 69, you're at risk, and less than 64, you're unlikely to be successful on the certification exam. But we don't want you to stop there. Even if you score 70 or better on the predictor exam, you need to go down and look at all your different knowledge areas. So we have cardiovascular here. This particular person scored 67 on this mock exam. Dermatology, 42. If you see the plus sign over here, you can always expand that knowledge area. And then it's going to show you what questions you got by diagnosis, and then which ones you got correct and which ones you missed. And so human bites, under the planning, they missed that question. So that would be an area that you need to go review, because maybe you're not.
And in fact, you know, we're going to talk about human bites when we do dermatology. Those are the dirtiest bites there are, as you probably know.
Right. So that's how you look at your exam, and that's how you help build your study plan, so that you know exactly what you need to look at to remediate. And you're not looking at, I mean, it gets overwhelming. This is 2 years of information, right? And so you can't go back over 2 years worth of time. Same thing in the review course. Dr. Amelie is very good about bringing in the high points in each knowledge area that you need to review. And so the predictor exam is another way that you can see what areas you need to review in. And when we tend to study, we usually try to focus on the areas that we're most comfortable in, because that makes us feel good. And we tend to shy away from the areas that we're not so comfortable in. And so this really helps you to focus in on those areas and maybe hit some of those areas that you're not so comfortable in.
So a quick overview, Kathy, is to kind of look at your colors, because the colors are like traffic lights. Green is a section that means you did well in. If it's orange or yellow, it's an area that certainly needs review. And then you can open it up to see what questions you know, you had trouble with. And then the red is obviously a section that you really need to beef up on. So if you are interested in one of these predictor exams, you can get it. You got an email that has a link. And the good thing about being on a hybrid course is that you're going to get the same exact discounts that you would get if we were in Phoenix. So look at the link in the email. Don't do it right now, but you'll see that we'll honor that same discount. And if you order any other kind of product, we will free ship it to you. So I don't know if that met everybody's questions, or that answered the question that our person had right before we convened this afternoon, Kathy.
Hey, Amelie.
Yes.
I get this question quite a bit. It's a single-use exam, right? You can't take that same purchased exam again.
Right. And you know, people always ask, why can't I take it again?
Yeah, it's kind of
because
funny.
this one is statistically predictable. So once you see a question, you should know what the answer is the next time you see it. And it's not predictable then, because just like your certification exam, the questions on there you're going to see for the first time ever. You're not going to see, no matter how many things you got on Facebook from your friends, you're not going to see the exact same question that, you know, your friend sent you. You're not going to see that on the certification exam. So that's a first time, you know, just like the APEA certification exam. So
Right.
we're proud of the score sheet because it helps you figure out where your weaknesses are. And right now you should have targeted study. You know, we'll talk some more about the exams, the 2 exams,
Right.
but
Someone
anyway.
else asked, is there only one exam? You can take multiple exams, but please don't use it as a practice exam. That's not what it's intended for. So, you know, I usually recommend 2. Take one, use it to build your study plan, take 2 to 3 weeks to remediate, and then about a week before your certification exam, you can take another one to see where you are, but don't use them as practice exams. They're really intended to be predictable for you.
Okay.
But each exam, you won't see the same questions on the second exam that you saw on the first exam.
Correct. And I think you can have up to 5 unique exams before you
Correct.
see questions again. So,
Mm-hmm.
All right. Well, hopefully that helps that person's question. And if it didn't, feel free to ask. All right. So, Dr. Kathy, can you help us? There we go. Just kind of some quick information in case somebody is on with us tonight who wasn't here earlier.
So you're considered an attendee. Dr. Amelie, Dr. Mimi, and myself are considered the panelists. That comes in if you want to chat and you want to send a chat to everyone. You want to make sure that it has all panelists and attendees that is selected in your chat mode. You can chat with all of us or individually. But if you have a question that is specific, please use the Q&A portion on the screen and type your question in there so I can make sure that we don't miss them. Because if you type a question in the chat feature for Dr. Amelie or Dr. Mimi, there's a lot of chats that are happening sometimes and I will miss the question. So make sure if you have a specific question for them that you put it in the Q&A so that I don't miss it, because it will stay there until I hit done.
All right. Great. Kathy, do you have a question for us?
Well, I have a comment.
Okay.
She says, my classmate, Sarah, says, my classmate just said she took her test 2 days ago and there was a lot on pregnancy, rashes, and STDs.
You know, every certification exam is unique and you never know whether you're going to get one that's heavy in pregnancy, a derm, or STDs. And so that's why I think you don't have to be an expert in every knowledge area, but you need to have a comfortable level of information. And if you have that, then you're going to do well. So, you know, I don't know.
Related to pregnancy, remember that we're just looking for basic concepts. When to take care of the patient yourself, when to refer, when to treat, when not to treat. Just review your course guide and the basic lecture.
Yeah.
Right. And she said she passed. So,
yay.
Yay.
that's always encouraging, Sarah. Thank you so much for letting us know that she passed and letting the others know that she passed.
Yeah. The other thing about STIs is they're exploding in terms of numbers. So that's probably why we're seeing more STIs on the exam. The highest since records have been kept, written records. So that makes sense that there are a lot of STI questions.
Yeah, that's really scary.
Very.
Yeah.
Mm-hmm.
Okay. So do we have a question there, Dr. Kathy?
This says, we are all GCU students who used your QBanks and your programs.
Awesome.
Welcome,
GCU.
Right. There's not another, she said, we love you.
Oh, I wish I could be there with you. The closest thing I could do was the picture behind me.
That's awesome.
And I know that the best time to be in the desert is in the spring, and I'm just missing it so much. It's cool, and it's just the flowers, the cactuses are blooming. I love being at in the desert at this time. So it's, oh, I hate that I can't be there with you, but thank you.
So we have no open questions. I know that you guys probably have some, and so you need to fire them away at us. So that, because now's your opportunity. Mary said that, Mary, that's a loaded question now. She said, of those resources that are on sale, is there one you recommend above another?
Well, you know what? I usually tell people it depends on where you are with your study prep. It does. There's no one product for everybody. You know, I usually talk about, and I will right now, since it seems like this is a good topic, is about the exam. But, you know, everybody in this room is going to be in one of three places after this course is over. And what I want you to do when this course is over is to open your course manual or your downloads, your PDFs, and I want you to look through all of the information starting on page 1. And I want you to make a list. Everything that was not fluent to you, meaning you don't know it as well as your middle name. All of this information that you walk into the exam with, you should be able to spout out as easily as if I said, what's your middle name? What's the last 4 of your social? So it's got to be that fluent. As we go through and as you go through your course manual, any information that's not that fluent, that it doesn't come out of you that easily, I want you to make a list. I want you to put it on your list and keep making your list until you get to the end of the course manual. And then I want you to pull out your calendar. And I want you to say, oh my goodness, I have a terrible week next week. I can only do 3 things on my list. I want you to make those 3 things your goals for next week. If you look at the second week, you'll say, I think things are going to be better with COVID-19. I think I can do 14 things on my list. Make those 14 things your goals for week number 2. And I want you to march your way through your list. And then I want you to give yourself a couple of weeks and I want you to go take that exam. Now, when I told you to make your list and map it out on your calendar, that's going to be the best predictor of when you're going to be ready to take this exam. So I really want to see you do that. But back to my original statement, everybody in this room is going to be in one of 3 places. There's a group of people in this room who probably have a very long list. Because while you spent a lot of time in school, your family came first, maybe your work came next, and whatever time was left over, you gave to school. And maybe the time that you gave to school wasn't really exam prep. It was papers and things like that. Everybody is going to be in a different place. But if that's where you are, then I suspect that you have a pretty long list. You can still cross the finish line. I know you can. To have reached this point in your professional career, you got to be smart. So I know you can get there. But everybody will have a different amount of work that needs to be done to get there. So if you have a long list and you have a lot of holes in your knowledge base to plug up, consider either a guideline book or something that you can read quickly. Something with bullet points that will allow you to cover a lot of information quickly. Because, you know, you want to do this within the next several weeks, the next 2-3 months for sure. So that's what you need to do to plug up the holes in your knowledge base. There's going to be another group of people who have a pretty long list, but they feel like they have a lot of time and they can, you know, they can get through all the content. If that's where you are, you ought to begin to work multiple choice questions. And what I would tell you is the most important thing about a multiple choice question is not whether you get it wrong or right. The most important thing about a multiple choice question is the rationale. You should inhale the rationale. Just breathe it all in. You know why it's so important? Because it's going to help stretch your knowledge base. And right now, that's what you need to be all about. So that's where the second group of people fall. The third group of people in this room are going to be people who say, Amelie, I really put in a lot of time at school. I've been working multiple choice questions. I've been inhaling the rationales. I think I'm close. Like, I might be ready. If you really think that you're close and you're ready, I would encourage you to take a predictor exam. Take one so you can find out if you really are where you think you are. Because I want you to be successful on this exam. I mean, that's why we do it. That's why all of us on this call tonight, we want to make sure that you are successful. And I'm going to do, and so will Dr. Mimi, we are going to do everything we can to make sure that you're successful.
Yep.
So take that predictor exam so you'll know if you really are where you think you are. So I could go on and talk about the exam just because it's passionate, but I know we have some questions. What are they asking about, Dr. Kathy?
So one question asked about the Q bank, which you may have just answered. She said, is it helpful in testing with rationales, and when would be the best time to utilize the Q bank? Will it give us areas to study or highlight our weaknesses? It does. You can use it in test mode or review mode. The best time to use it is in that last semester of school. You know, if you've got about 4 weeks before you take your certification exam, it will probably be helpful to you to remediate your weak areas based on the predictor exam. And so if you're weak in cardiovascular, you can go to the Q bank management, pull up the cardiovascular section and answer questions that way, either in study mode where you answer the question and it gives you the rationale, or you can do it in test mode. It will give you some analytics on what you're missing, so you can see that, but it's not predictive. It's just helping you to learn. And like I said, those meaty rationales that are there, and like Dr. Amelie said, are really where you're going to learn the best.
Yeah, inhale the rationales. Those questions are intended to help teach you things. And they're very, very good in your exam prep because it stretches your knowledge base. So
yeah.
So there you are.
So,
what else are they asking about, Dr. Kathy?
Megan has a question. She said, I have a question on neurology.
Okay, perfect.
Yep. When diagnosing and treating dementia, how do you word the order for an MRI so that it will be approved by insurance companies? If the MRI, if the MRI is negative along with other diagnostics, do you initiate treatment or refer? And does dementia need to be diagnosed or treated by specialty?
Oh my goodness, that's a lot of questions.
It is
I'm
a lot of
glad
questions.
you asked that, Megan. I'm going to ask Dr. Kathy to help me. Dr. Kathy's expertise, among others, is neurology, and in particular, dementia. So, Kathy, where can they start? Where can she start with that?
So, obviously the first point of contact is going to be primary care with a person who is having some deficits in their everyday life. And so they're not functioning to the capacity that they normally do. And usually it's a family member that brings them in and says, you know, mama's not, her lights have been cut off 3 times in the past month.
Because she forgets to pay the light bill.
Right.
You know?
And that's not like mama. Mama always kept a great balanced checkbook and always has been on time with her bills. And so it's things that are out of character. We do have the MMSE that we can use to screen, and you should do that. That's going to give you a high level of suspicion. You know, sometimes neurologists, unless there's other things that are there that are adding in their differential list, they may or may not get imaging. And so, but that would be a neurology place to start. So I probably wouldn't even worry about an MRI. If I had a really high suspicion that it was dementia in primary care, I would probably go ahead and refer them over to neurology. And if neurology felt like they could get an MRI, needed an MRI, they would get it approved quicker. If you did have a level of suspicion and more things on your differential list that you needed to rule out before you got to dementia,
you need to do that in primary care.
You do. You need to do that in primary care. And your diagnosis, your rationale for getting the MRI, you're going to have to go through the steps of whatever insurance company requires from you. It does matter your documentation of those symptoms. And so as many symptoms as you can put that person is having to justify why you're getting the MRI is going to help you. Your documentation is going to help you.
The documentation is always what gets you in trouble or gets you out of trouble.
Or gets you out of trouble.
You know, you start with a really good history, and once you begin to show that there's some suggestion of dementia in the history, and you have another person who comes in who, you know, confirms that the patient's responses to the questions are not what match, you know, the person who knows the answer, then an MRI is not going to be the first thing you do unless it's something that makes you suspect a tumor or something like that. You do your cognitive testing, just like Dr. Kathy said. She mentioned the mini mental state exam. The MOCA is also used. That's going to be part of your documentation, and their score is not going to be stellar. And then you're going to do some labs to rule out that something underlying is going on. I always think about how embarrassed I would be if a patient was having cognitive issues and it was a B12 deficient.
Folate, exactly.
Right.
Yeah, so you start and then you go into your labs, and if everything just keeps building a case for something like dementia, then you make a decision about whether or not an MRI is needed. But if you feel like the MRI can uncover something or just rule out everything else, once you have that documentation, somebody usually gives you authority to get the MRI.
Make sure they don't have a urinary tract infection.
Oh my goodness. Thank you, Dr. Mimi. That's a great point.
Yes. And so other symptoms, if they have dizziness and they have a new onset dizziness, that in itself may be enough, along with everything else, to get the MRI. And that's what we mean by other things there that are adding to your differential list.
Yeah, or even headaches. If there's something that makes you think this doesn't really look like dementia, that's when you begin to you explore more. And the exploring usually costs a lot of money, as you might imagine. All right, so hopefully that helped you, but thanks for asking that question.
So the second one is from Jamie, and she says, with neuro disorders, there was not a lot of in-depth info on medications.
Okay.
Do we need to focus on specific meds for these issues, such as headaches, dementia, tremors, or just the classes of medicine, or does this in-depth info come later in the videos?
I would tell you that most of the time within your exam questions, they refer to a class of medications. And I'll tell you this, anytime you see a box that I've developed, like a medication box, it's got classes and some examples and something else, those are medications that I didn't just pull out of the air. They're medications that people who've taken this exam have told me were on the exam. So I'll put them in these boxes for you. So that's where you can start. But if you know the classes of medications and some of the older drugs, just a common example, you'll be in fine shape. Of all the questions on the exam, probably the fewest come in the realm of neuro. So I think you're going to be in fine shape without knowing detailed drugs for dementia and tremors. And if you know the basic things, I think you'll be in fine shape to get a big P for pass on your exam.
Correct. I agree with that. And
especially,
if you're going to use
especially the differential, right, Amelie?
The differential, yeah, the differential is huge. And, I always think about Mimi with differentials, and let me tell you why. You will distinguish yourself as an excellent nurse practitioner if you can build a good differential diagnosis list. Mimi always talks about differentials. I always talk about differentials. If your patient's diagnosis is not part of your differential, it's very unlikely that they're going to get the right treatment. So building the differential is tremendous. And it allows you're going to distinguish yourself as an NP when you can do that. And it takes practice. So that's an important point. Thank you for bringing that up, Dr. Mimi.
I always think of that instant workup book, these little books that we have, one for adult and one for PD, that help you know what test to do to rule out what problem for all the chief complaints. It's just really, really handy.
Yeah, that's one of Betty's favorite books. Betty's a nurse practitioner, and Mimi's too. Yeah, Betty works with us, and she's probably been an NP for, 30 years or 35 years. And she loves the book. Mimi does too. So that's pretty good indication that it's a good one.
Yeah, it's called Instant Workup for Medicine, and there's one for pediatrics. And so I would agree with all that on the medications. I do think you need to have some awareness of the headache medications, but in the realm of neuro, that's probably the most in-depth on medications that you're going to get is for headaches. Okay, second question on neurology. Vertigo. if you cannot rule out central vertigo, this is from Megan, do you advise sending the patient to the ED or to neurology?
No, I think you have to wait or you have to look and see how urgent and what are the symptoms accompany vertigo. But central etiology means it involves the brain, and usually at that point they either go to an ER or you are the one who's going to order an MRI. But symptoms of central vertigo are always concerning, especially when you can't rule it out. And I think I told you about putting a sticky note on the exam room wall and drawing a circle in the middle and coloring it in and getting the patient to focus on that circle. Because if you can't make their vertigo stop by making them focus on that for 1 minute without shifting their gaze or moving, give them 1 more minute. But if you can't stop the vertigo, it's central until proven otherwise. And, you never want to just wait on a central etiology patient. So depending on what you think is the etiology, you either got to get an MRI or send them to the ER, where one will usually be done pretty quickly. But it's hard to get patients into neuro, and you don't want them to sit with something that's very serious going on. Maybe it was a stroke. I remember having a lady one time who'd had a stroke. She was dizzy for 2 weeks when she came in to see me.
Right.
And it takes a while to get patients into neuro, so you don't want them to sit with something serious, just like waiting for their appointment. So,
Hey, Amelie.
yes.
Should we document that as a positive sticky note test? Just kidding.
Mimi, if you can document something as a positive sticky glove sign, people will hear about tomorrow. I could document that as a positive sticky note test. Good one, Mimi.
Thanks.
Yeah, good one, Mimi. Okay, this is from Sarah. Sarah says, at times I confuse the titers for hepatitis. I watch the videos and think I have it down, and then sometimes pick confidentially, and then other times choose an incorrect answer out of your question book. So can you suggest another tip to help keep those straight?
I'll bet you that she's talking about hepatitis B, because hepatitis B is the hardest of the 3 to interpret. And, I'm looking at this right now, and I'm thinking that if you go in the GI section and you look at the hepatitis chart for Hep B that I created for you, I think you'll find it to be really helpful. And, there are really 3 markers you need to know. One is a surface antigen. And anytime a patient has a positive surface antigen, it means they're infected. They are infected. And the only question is, are they acute or are they chronic? So positive surface antigen, you're infected. A positive surface antibody means you're immune. And if you're immune, my question is, how'd you get to be that way? Did you get the immunization, or did you recover from the disease? So that's the second of the markers. And then the third one is the one with the little c. And that little c is an antibody to the core of the virus. The only way to get an antibody in your bloodstream that's to the core of the virus is for the virus to have been inside of you. So I think it might help if you really review those 3 hepatitis B markers, because once you understand what it means, then I think you'll be able to figure out the answer. And if hepatitis B is not the one you were asking about, shoot us another question, because I want to make sure we address it. I tell people, you can't leave today unless you know how to interpret your hepatitis markers. So, and I want that to be your experience today. So if I didn't address it, I want you to send another question there so I can make sure we get it. Thanks for that question.
That's good.
She said, yes, it was B. And Sarah, I've heard some people, some students that have commented that they basically make themselves a little story with the hepatitis B of who comes to visit and when they come visit and how they come visit. So basically it's the hepatitis B family that's visiting. And so they made themselves a story to help be able to recall what Dr. Amelie just went through of how you arrive at that. So that might be a good tip for you. So, okay, let's see, what do we have here now? So she answered, see, she answered the anti versus surface core. Okay, she answered that. Jamie says, with the TIBC, what is the main purpose for checking this, i.e. the etiology, and what does it help rule in or out?
Okay, so maybe we can take one of those one at a time. Dr. Kathy, you have to walk me through it.
I sure will.
The TIBC, remember, is an acronym for total iron binding capacity. It's the ability to bind iron. So here's how I kind of explain it. I get people to look at the palm of their hand, and I remind them that the palm of their hand is just like a red blood cell. And each of your fingers, hopefully you have 5 of them, each of your fingers represents a place where iron comes and binds. Because the secret about iron is this: iron just wants a home. Iron hates to swim around and around in the bloodstream. It wants a home, and when it finds it, it's not getting up. Consequently, if a patient has iron deficiency anemia, they don't have enough iron swimming through the bloodstream, so they have a lot of iron binding sites that could accommodate iron, that have the ability or the capacity to bind iron. So, you know, the analogy I gave you, I believe, was the egg cartons. And it's the ability of red cells to bind iron, the total iron binding capacity. So when the capacity is low, it means the iron count is elevated. And, you know, if you look at an egg carton, I think it'll help you see it. The empty egg carton obviously has a high capacity. And so hopefully that will help you see it. What else did she ask about, Dr. Kathy?
So what does it help rule in or out?
Well, it helps to rule in or out iron deficiency anemia, and here's why. The serum iron level is affected by what you just ate. It's affected by iron that you might have just gotten in a multivitamin. So while the serum iron is something that we check, it can be affected by many things, like what you just ate or a multivitamin. And the serum ferritin level tells us how much iron you have in storage. But the serum ferritin level can be influenced by anything going on in the body that's acute and inflammatory. Because serum ferritin, and I don't think I told you this, and you don't need to know it at an entry level, but serum ferritin is an inflammatory marker. So some people who have underlying rheumatoid disease, lupus, sarcoidosis, anything like that, will have an elevated serum ferritin level. So the serum ferritin is not always a good means of looking at iron deficiency anemia. So we look at the total iron binding capacity, and we look at all 3 of them together, because all 3 of them help us figure out the story. So the serum iron can be affected by what you ate. The serum ferritin can be affected by like inflammation. And the TIBC is usually a really good prognosticator for iron deficiency anemia.
So summarize when the total iron binding capacity is high, they're less likely to have.
If the capacity is elevated, it means there are a lot of places where iron could come and bind.
So they're more likely to be
low
anemic.
Iron levels.
So they're more likely to be anemic.
They're more likely to be anemic, exactly.
It's counterintuitive for students to remember.
It is. It's called, like the term is called a reciprocal relationship.
Yep.
Meaning it's the opposite of what you think.
Yep.
So just keep visiting that concept. And I think once you visit it and you look at it, it's going to find a place in your brain to light. But, you know, these are concepts that are not easy. You know, easy is 4 + 4. You can memorize it. But it's the understanding of these labs that requires a higher level of learning. And usually you have to visit it multiple times, and then you'll have it. So be patient with yourself, because it's going to come along. But the first or second time you look at it, you might struggle. That's totally normal.
Thank you, Jamie, for that question. So Megan says, thanks for answering so many questions. Can you please talk a little about G6PD? deficiency.
Okay.
It was included on the exam checklist, but didn't come up during the lecture.
She's exactly correct. And that tells me that she's listening very carefully. So I'm already impressed. G6PD is an acronym for glucose 6-phosphate dehydrogenase. It's an enzyme. And almost everybody has this enzyme. But if you don't because you didn't inherit it, the ability to make it. So if you don't have G6PD as that enzyme, if I give you a prescription for Bactrim, you're not going to be able to metabolize it. And you know what's going to happen? Your red blood cells are going to pop. They're going to burst. The word we use when a red blood cell bursts is called hemolysis. And if you hemolyze enough red cells, like you just killing them left and right because you don't have that enzyme, and I give you Bactrim, your H&H is going to drop, and it creates a hemolytic anemia. So it isn't just Bactrim that could do that. Aspirin can do it. So those are the two most common ones. But you know what else can do it? Fava beans. Fava beans are a staple in the Mediterranean diet. They're very healthy beans, but fava beans can also precipitate hemolysis if you're not able to make that G6PD enzyme. So it's not real common, but I have a family of patients who all have that deficiency. And they only learned about it when the mama ended up in the ER with an H&H of 3 and 12. And she was so dizzy when she sat up, that's what brought her in. But she was grossly anemic. Someone had put her on a prescription of Bactrim at an urgent care center and didn't ask her about that because not a lot of people have it, but it made a real big difference to that lady and for her whole family. So G6PD, glucose 6-phosphate dehydrogenase.
Do you think most patients know that acronym?
No,
Is
they
that a
just say
history
I
of
have,
it?
they usually say I have something in my blood I can't take
Yeah.
Bactrim.
Yeah, exactly.
You know, and I can't tell you I've seen 1,000 people with this, you know, maybe a dozen over 25 years.
Mm-hmm.
But, you know, when you see it, it's impressive because if you give them the wrong medicine, they can have a really bad outcome. Bactrim, aspirin, fava beans.
And that's a good point to being sure, because a lot of times the social history, the medical history is all put in by the MA or the nurse who's putting your patient in the room. And so, especially with electronic health records, we're not so good about clicking on those histories and looking at those. And we really should be, just for instances like that. Because the patient's already put it down once and they may not remember to tell you again because they're thinking that you're looking at their history. So please do.
We are responsible for that history review.
Yeah.
Yeah.
I always think about you, Mimi, about history and a factor V Leiden disease. And I think you'll talk about that tomorrow in Women's Health. But history is just so important. Always important. Not common, factor V Leiden. G6PD, not common.
Right.
If you miss it, the patient can have a really bad outcome.
Or downright kill the patient. It's bad for business, as Amelie says.
So we don't have any more questions, Dr. Amelie. I don't know if do you have any of the review checklists that are available that you can share and see if that maybe stimulates a few questions?
Well, one thing I would tell you that the exam question writers are focusing on right now are imaging studies in GI, because they want to make sure that you are a cost-effective provider. And I did something that I think you'll find really helpful. It appears right after the exam checklist, and it's entitled Summary of GI Imaging Studies. And I think that will be very helpful to a test taker. So a word to the wise, it's the content right after exam checklist in GI. It's a summary of the GI imaging studies. That's a really big one. It really is.
And Dr. Amelie, can you tell them how to find the pediatric portions of the review course?
Oh, what a good, yes. Thank you for saying that. So listen, you're going to get the videos, and we're going to talk about the first 2 days of the course. but you have a lot more information that is available for you. So if you were at the live course, this would be online for you. Let me tell you what it is. You have pregnancy that Dr. Mimi does. So I would pay attention to that. They just want you to be able to monitor a normal pregnancy and recognize abnormalities. Know what drugs you wouldn't give them. So pregnancy is online for you. But pediatrics is pretty rich. It's got a growth and development lecture, which people always ask me, oh, I don't have to know all that growth and development, right? I don't like peds. Well, they're not going to ask you, what can a 6-month-old do? But what they often will do in pediatrics is give you a 6-month-old who's brought in because the mama thinks they have a otitis media, an ear infection. And when you manage or you work with this 6-month-old, he can't sit up. In fact, he's got poor mouth coordination. So they don't tell you that that's not the meeting of a developmental milestone. Instead, they ask a question like, what should be done initially? Give amoxicillin, recheck the ear in 2 weeks, assess for further developmental delays. And so obviously that's going to be, the best answer. So they don't ask you things like, what can a 6-month-old do? What can a 1-year-old do? Instead, what they do is, they give you one of those age patients and they just mention that they weren't meeting their developmental milestones. And so that's how they arrange that. So there's growth and development for you. I've done that one. And there's PEDS part 1 and 2. And what else is in there, Dr. Kathy?
In the supplemental information, there is entry into practice, which I recorded. So that may not be something you want to watch right now, but you do have it available to you so that once you pass that certification exam, now what do I do? So it walks you through all of the licensure and numbers that you need to get in the process for doing that. And finding a job if you don't have one already.
Yeah, and it's a good one. And as I mentioned, Dr. Kathy is president of our State Nurse Practitioner Association. She is the person who did the entry into practice video. So she knows from where she speaks, and she's really helped people get through all the licensure and all of those things, how to get a DEA number, and she's been through all of that, and she gives you some of her best tips in that video. So you might not want to watch it at this moment, but
right,
you would certainly want to watch that.
And I am interested in helping you guys because I blushed a lot during my process. Just the NPI number, for instance, I was working at an institution, and the little pharmacist came over and said, do you have your NPI number yet? I was like, I don't even know what an NPI number is. She goes, well, here's where you go. Here's what you do. So I filled out all the applications. She comes back in about a week and she goes, did you get your NPI number yet? And I said, no, I haven't seen a thing. So she comes back in about another week and she goes, did you get your NPI number? I said, no, I mean, how long does this take? And she goes, well, you should have gotten an email as soon as you hit submit. And so I did, and sure enough, there was my NPI number. So immediate.
That's good.
So I want to help you guys not have to do that.
Yeah, we all want to help you. We want to make sure that you're successful. So, let us know what we can do to help you. And, maybe you're tired and you're ready to go home, but keep your list of questions because we're happy to answer them. And, we're going to do what we can to get you where you need to be. So,
Dr. Amelie, can I mention just something about the mood disorders lectures? I think
please
should have watched that.
Mm-hmm. They should have. Yes, that would have been this afternoon.
I want to remind you that on the exam, they may ask you a question about a screening test for a particular condition, whether it's depression or anxiety, and you want to remember to answer the answer that's specific to the screening test, that's specific for the population that you're screening. So if it's pediatrics, you're looking for a pediatric screening test for depression, elder screening test, pregnancy screening test. Be really careful on that. If you're suspecting a mood problem, your answer to the question of how do you proceed next, labs or a screening test, it's always the screening test before the labs.
That's great advice, Dr. Mimi. You know, we talked about quick, cheap, non-invasive, and you can do it in your office. The screening test meets all of those. That's
Yes.
always the right answer on the exam, by the way. If the test or whatever it is you can do is quick, cheap, non-invasive, and you can do it in your office, always the right answer.
And do you think they'll ask about specificity, sensitivity and specificity on those tests?
I do think you're going to see it on both exams, both AANP
Okay.
and ANCC.
So you
And-
really want to review that. Amelie
Yeah.
and I both talk about sensitivity and specificity. Sensitivity is the ability of the test to identify the problem that you're looking to rule in. So if it's depression, it's ability to identify depression in that particular patient.
And it's
And
a true
specificity,
positive.
it's a true positive.
Positive.
And the specificity is the true negative, the ability of the test to rule the problem out. So you want to be
And you really
careful
don't
to
have
keep
it.
those-
Right.
That's right.
Yeah.
That's right. And you will have, you know, ANCC has been known. I saw a question pop up, but that it went away. ANCC has always been known for asking a lot of role questions and supplemental questions like that. They have changed their blueprint, like we talked about earlier. But you know, you may get a few questions on AANP as well that are similar to that about sensitivity and specificity and research and role. There won't be a lot, but don't be surprised. I've heard a few students, they're like, oh my gosh, I didn't expect any of that. It is a possibility.
Yeah.
So
And you
We
know
don't
what?
think you'll be asked about the exact percentages, Amelie. Is that still about the case? You know, which test is best in the context of, say, there are 6 depression tests. Which test should you use based on the percentage of accuracy? I don't think they're going to ask that. Do you?
Oh, no, I really don't
No.
think they'll
Okay,
ask
great.
that.
Because a lot of
No.
students get all nervous about that.
Mm-mm,
Yeah.
no.
Okay.
So we do have another question, Dr. Amelie,
Okay.
from Emily. In
Alright.
talking about the G6PD, she
Okay.
said, how is that usually discovered? Is it something that they're screened for, or when they just become symptomatic? How is it usually discovered?
You know, there's a battery of tests that are often done on a newborn, and it's often discovered as part of newborn screening. It depends. It's real state specific, though. I know for a time, Louisiana always checked G6PD. Like, for example, Vermont always checks, and I'm not from Vermont, but they have a maple syrup disease,
Oh my gosh,
so-
that's so funny.
right? So they always screen for that.
Serious?
And yeah,
Oh, I gotta Google that.
So every state has a set number of tests, but you know, every state screens for PKU, and you know, they have some that, and they're growing and growing. The more we find out about genetics and inherited diseases and disorders, the more the list of routine newborn screening, the list grows and grows. But G6PD is in most states because it's really a big deal. It's a very big deal. And it's, again, it's not common. It's like PKU. It's not real common. But if you have it, you in for big trouble if it's not picked up and the wrong set of circumstances is there.
That's right.
What else do we have? I think we might have some tired people.
I think
Oh,
so.
sure.
I have
Happy
no more open questions at the moment.
Okay.
We're coming
Well,
up on
this
the hour.
session- Yeah, this session was recorded, and it's going to wind up in your CE Center box, so that if you were just tired and didn't get it, or one of your friends wasn't able to listen to it, it'll be available in a recorded version. But I think we can wrap it up unless somebody else has a question.
Sarah said she has some on women's health and pregnancy, but she'll save those for Dr. Mimi tomorrow.
Oh,
Okay,
good.
that would be good. Well,
Great.
I
Thanks,
Sarah,
enjoyed
you're
it.
on. Thank you.
Thank you, Dr.
everybody.
Kathy and Dr. Mimi, and we'll see you tomorrow.
All right, great.
all.
Have a
All
good
right,
night.
y'all have a good
Good-
evening. Go
some
rest
rest.
your brains. Go rest your brains. Bye-bye.
Bye.